The first third of your pregnancy is called the first trimester. It's made up of weeks 1 through 12 or 13 of pregnancy. When conducting a first trimester ultrasound assessment, sonographers need a minimum of a two-dimensional ultrasound with the capability of adjustable power output, freeze, zoom, electronic calipers, and the ability to either store or print images to be saved. A full bladder is ideal to accomplish the transabdominal exam. The distended bladder displaces the uterine fundus posteriorly, creating an acoustic window, enhancing the resolution of structures deep to the bladder. Occasionally, thin patients with antiverted uterus can have early pregnancies successfully evaluated transabdominally with a high-frequency linear transducer, but requires that the target depth is at or less than 6 cm. If the transabdominal ultrasound is unsuccessful or further clarification of structures is needed, transvaginal ultrasound using an endocavitary transducer should be performed with a decompressed bladder. Endocavitary transducers should be covered in a clean sheath. Ultrasound gel inside is either preloaded or manually loaded, and lubricating jelly is used exteriorly. Do not use ultrasound gel on the probe cover's exterior as it irritates mucous membranes. To perform the transabdominal ultrasound, utilize the curvilinear probe and select the obstetric setting. The obstetric setting will load any requisite calculation and labeling packages needed to perform the complete evaluation. With the indicator oriented to the patient's head, mid-sagittal orientation, the transducer is superior to the pubic symphysis. The bladder is usually easily visualized when distended, filled with anechoic fluid in a triangular shape. Make note if the cervical os is open or closed and if any products of conception or tissue are lodged in the cervical canal. An endovaginal ultrasound should be performed if a gestational sac cannot be adequately visualized by transabdominal exam. If and when a gestational sac is visualized with or without an embryo or fetus, the sonographer must confirm it is within the uterus itself, as some ectopic pregnancies may lie adjacent to the uterus. As discussed above, visualizing the double decidual sign is one way to confirm this. The mean sac diameter is the earliest method used to evaluate early pregnancy and requires using the sum of the length of the gestational sac plus width of gestational sac plus depth of gestational sac divided by 3. The first two measurements are taken in either the long or short axis and then the third measurement in the alternative axis. A common mistake occurs by measuring the anterior-posterior distance, transabdominal or cranial caudal distance, transvaginal, twice. If a fetal pole, embryo less than 10 weeks or fetus greater than 10 weeks is visible, further gestational age estimations are obtained by either crown rump length or by parietal diameter. In the first trimester, crown rump length is the most accurate metric to determine gestational age. Why? Because there is little biological variability at that time. The sonographer should optimize the image for this measurement by employing appropriate depth and zoom while maximizing the length of the fetal pole on the screen. Once optimized in the longest axis, freeze the image and measure crown rump length with the electronic calipers, ensuring that the yolk sac is excluded from the measurement. For the most accurate dating, several measurements should be taken and averaged. Biparietal diameter may also be performed with similar accuracy to the crown rump length between 12 plus 0 and 13 plus 6 weeks. The image should be optimized to zoom on a symmetric short axis of the fetal head. The third ventricle, choroid plexus, and interhemispheric fissure must be in view for accurate assessment. The measurement is taken across the broadest diameter from the inner wall to the outer wall of the cranium. In terms of pregnancy ultrasound, viability refers to an active embryo fetus with a heartbeat at the time of the assessment. An empty gestational sac with a mean sac diameter greater than 25 mm is diagnostic for a non-viable pregnancy. Cardiac activity is often seen when the embryo is at or greater than 2 mm in size and indicates viability. Conversely, a failed pregnancy can be diagnosed when a fetal pole measures 7 or more centimeters without an evident heartbeat. Lastly, Pregnancy failure can be determined when 2 ultrasounds are performed at fixed intervals, typically 7 to 10 days, without evidence of an embryo. Pregnancy failure is suggested when the yolk sac diameter is greater than 7 mm, when the amnion is seen next to the yolk sac without an embryo, and when the gestational sac is disproportionately small compared to the embryo. Thanks for watching. God bless you. Please subscribe if you haven't.